Hi, good evening, girls. I'm very, very happy and proud today that Beating Hearts has managed to start. This is our very first webinar on nursing. And I'm very pleased that Miss Ho has so kindly agreed to give us this webinar. And Miss Ho, of course, is very well trained and is a trainer, okay, in oncology, nursing, okay, with 20 years of experience. And I'm also very proud that, you know, Miss Ho has gone on from a nurse to trainer to now being in the admin of a hospital. So what do you do now, Miss Ho?
Actually, yeah, hello everybody. Thank you for your kind introduction. Actually, when I joined Beacon Hospital, still I interested in training. So I agreed to become their learning and development department, leading a group of nursing clinical instructor. But after 6 months on board, upon confirmation, the CEO approached me and said, what about you help me to take care of the whole human resource department? So I took it as a challenge, but learning and development is still one channel, part of human resource, just that now a bigger portfolio, a bigger umbrella. So until today, it's almost 2 years I'm in Beacon Hospital, and I'm enjoying what I'm doing now, and I learned so much and very interesting. But I never miss because I never lost touch. No chance to miss because I'm still conduct ongoing training, ongoing webinar.
Okay. Yes,
for Beacon Hospital internally, because Beacon Hospital is a cancer-based hospital, so they vastly needed my knowledge and skill to train internally the whole hospital nurses. Yeah. So
So maybe without further ado, we start on this webinar.
Sure.
Okay.
Sure. Yeah, you need to hint me if I talking too long and might drag more than 1 hour.
Okay.
So actually within 1 hour to finish this topic, okay, a bit challenge, but I make it simple because
next week we have another hour.
Yeah, that one another troubleshooting topic, right? Next week. Yeah. So I take it like most of you is not post-basic oncology, nursing, or specialized cancer training. So I make it simple. Any question in between? Are they allowed to ask question, or this is one
yes,
way?
Of course. You can raise your hands, they can unmute, or they can type the question into the chat.
So you prefer the Q&A in between, or you like to accumulate
I think maybe we do
the end?
Q&A at the end.
Sure. So you accumulate the question. So let's start. Topic for today given is care of Cvad, and the most common Cvad used in adult setting are chemopod and Piccc. And some of you like to call Cvad CVC. Actually, it's equivalent. Okay. The learning outcome for this evening is I want to, from simple to complex, introduce what is Cvad, central vascular access device, and I like to zoom into some important feature of Cvad so that you can understand better why when I teach you the skills and procedure, and when I go to my second webinar on the complication and troubleshooting, it's much related, this fundamental knowledge about Cvad. Yeah. Then we will end with some skills on blood taking, flushing, and dressing on chemopod or Piccc. This one, I keep it to next webinar. Okay. Cvad, as I said, some like to call CVC, is equivalent. CVC means a central vascular catheter or central vascular access device. Yeah. Some misunderstood CVC is the neckline. They call the neckline CVC, but other CVC are not CVC. Actually, it's not true. Chemopod also a CVC. Piccc also a CVC. Jugular vein, your subclavian vein catheter, all are CVC. Okay. Later, some who always call wrongly, you sometimes might laugh at yourself at the end. Okay. So CVC or Cvad is an indwelling intravenous device that inserted into a vein of the central vasculate. Sure. Okay. And the tip of the CVC or Cvad usually rests in the cavo-arterial junction. Okay, CAJ. So the tip is always end at the cavo-arterial junction. So before I go into detail what is PICC or chemopod, as you can see in this picture, there are various types of Cvad. Peripherally inserted central catheter, which is PICC. I think Dr. Betty, you need to mute somebody.
Yeah, that's what I'm looking at. Yeah.
Okay. So PICC, second type, where you like to call this a jugular vein or subclavian vein catheter as CVC. So actually, CVC is a kata nama arm, you know. All these four types are CVC. But the neckline that always you like to call is CVC got specific name called percutaneous non-tunneled catheter. Okay, because it punctured directly into your vein without any tunnel under subcutaneous layer or under your skin. Another type of catheter where it tunneled under your skin at the subcutaneous layer are called tunneled central venous catheter, such as your Hickman line is one of the example of tunneled central venous catheter. Okay, so tunneled and non-tunneled. And last type of Cvad are pod, okay, an implantable pod, implanted pod. And in Malaysia, mostly we like to call it chemopod. But actually implanted pod not only meant for chemo, and it's not only meant for venous, okay? Because implanted pod at the tip of the pod can reach in the venous or even in the peritoneal or even in the intrapleural cavity or any cavity. Just it's a implanted pod. Okay, but it's very common use in intravenous, and most of the time people who need chemo and cancer patient would like to put it in. So that's why a lot of clinical staff like to call it chemopod.
Can I ask?
Sure.
Okay. What is the difference between the tunnel and non-tunnel? What is there an advantage?
Yes. The advantage of tunnel is it can last longer because from the puncture site until after puncture through the skin, the catheter is travel under the skin, like under the tunnel, okay, at the subcutaneous layer, and with a certain distance, then only the catheter enter into the vein. So that gap from the puncture, the exposure of the skin puncture till it enter the vein, that distance will further prevent risk of infection. In another hand, the non-tunnel, the puncture site is so close to the big vessel. So it's very high risk of infection, and you cannot keep this non-tunnel catheter such as your subclavian line, your jugular line, right? You cannot keep long. The max is like few weeks, and you not advised to allow patient with percutaneous non-tunnel catheter to discharge with this non-tunnel catheter because the risk of infection is so high, and we worried that they do not know how to manage it. And usually it for emergency situation, like temporarily when you're creating the AVF for dialysis patient, or while you arranging for other more longer stay in Cvad or CVC, such as Hickman or PICC or POD, you temporarily need this non-tunnel catheter, especially like a leukemia patient during tumor lysis condition. Yeah, then you want to reverse the tumor lysis syndrome, then you quickly put in the non-tunnel CVC, so that after certain treatment, patient more stable, platelet a bit better, then only you go for all others CVC.
I see. Okay. Another question is, Can
I thought you want to keep the question till the end.
Yeah, but I'm a moderator, so it's different.
Oh, double standard.
Yes. Okay,
Okay.
because if not, I cannot remember. So the implanted port, you say, it is best for, it is used for, let's say, as a CVC, but it can be put into a peritoneum or pleural cavity. What would, okay, what is the purpose of this port when they put into this third space cavity?
Okay, so it same go to your pectoral catheter when you want to do peritoneal tapping for the ascites cases. You put in a pigtail, right, to do abdominal tapping. So for some cases where they've got frequent required for abdominal tapping, maybe they are liver cancer with chronic ascites, so they don't want to keep a pigtail or frequent insert and remove the pigtail, admit and discharge. They even can permanently implant a port to the peritoneal cavity, and they just need to insert the needle to this port and can connect to the drainage bag, and it's considered the abdominal tapping already.
Oh, interesting. Okay.
Yeah, but of course, the product of the port is a bit different series. You cannot choose the intravenous port to implant for peritoneal. The lumen of the catheter can be larger because of, you see, the fluid is different. It's not blood now. Now it's the peritoneal fluids with a lot of fibroid, all those things. So the lumen, the product a bit different. So they of course will choose the appropriate port lah.
Oh, interesting. Okay.
And needle size also different. Okay. So now come back to my first my intention here to before I go into each CVAC, but actually today I more because I zoom a bit to port and Piccc later, but before go to specific CVAC, I want to introduce the common so-called specs or elements of the CVAC, which they are single lumen or multi-lumen CVC available out there. Okay, such as Piccc, you do have single lumen Piccc, double or even triple, right? Same goes to any CVAC. There are single or double or triple, even the port. Okay, although it implant underneath the skin, also got single port or double port. So this is available. Single, double, triple catheter are available in all types of CVAC. Okay. Then interesting question might pop up, but the rest is keeping the question till the end. But Dr. Betty now not asking. Okay, fine. I bring up some questions so that I worried some forget to ask at the end.
Yeah.
Let me test you all. So since it got double lumen, triple lumen, yeah, the catheter, you look at the Hickman line, okay, the tunnel, although it's double lumen catheter, but at the end, it still go into one catheter, right?
Yes.
Yes. So can we concurrently infuse incompatible medication?
Incompatible. Okay, so this is a very good question.
Yeah.
And, can you guys just answer a yes or a no on the chat? Okay, so we can have an assessment of what you think. Okay, Nitya says yes. Come on. Anyone else? Can we infuse two non-compatible infusion into one?
Concurrently. At the same time.
So everybody says yes. So far, we only have yes. Okay, I'm also learning, okay? Yes.
Dr. Betty, what do you think?
I think yes. I think yes.
But
I've seen the nurses do it.
Yeah. Some you follow the stream. Okay, some might guessing yes, but do not know.
No, but the majority
rational
so far is yes.
Good,
Almost
very
everybody.
good.
Unanimous.
Yeah, very good.
Yes.
Yeah, very good. So actually it can. Yes, it can. Because each lumen it looks like this when you cross section the common lumen at the end. Okay, or this obviously is a triple lumen catheter. So when it go to the common catheter, when it combine, join to one catheter that time, actually inside they are separated. Okay, so the three drugs actually is not mixing up at all. All right, but however, why I need to share this point with you, where is same goes to when you do flushing. You do not think that I flush either one of the catheter, it already flush my whole line nicely, but actually you only flush one of the lumen. So you must treat each lumen separately, and you need to flush all three lumen when you want to perform the routine flushing, okay, to prevent blockage. And incompatible medication can be infused simultaneously via these red lumen.
Okay, hold on.
Okay. Some might think, but just now Ms. Ho said the tip of the catheter placed at the atrium, vena cava atrium junction there, right? But what if when all these three drugs exit from the catheter, will they mix up and mix at that time, right? But the answer is also no, they won't mix, okay? Because if it's a double lumen or triple lumen, the exit port at the tip there, actually they got approximately 2 cm apart, okay? So they got different exit site. And this another feature that I like to highlight is all CBC product or Cvad product, they are option of product, whether it's a closed-ended or open-ended product. So what's the difference between these two products? Closed-ended, there is a valve, yeah, whether it's at the tip of the catheter, the top cartoon, okay, the top picture there, actually the valve at the tip of the catheter. So when it aspiration, then you can see the valve is open up. When you infuse, also you can see the valve open up, right? Invert or revert, see? But when there's no suction or pushing, that means no aspiration or infusion, the valve will seal off itself nicely, okay? And it's just a line which is it closes itself. So this valve, the function is it can prevent blood backflow. So since it can prevent blood backflow, do you think all Cvad need a clamp? Actually, I already hint, okay? Since it is a closed-ended, you might not see this closed-ended Cvad come without a clamp. So you don't get a shock when you see the Cvad, because you see, okay, Cvad usually come with clamp, right? You see, the Piccc got clamp, all this got clamp. But one day, if you see a Cvad, a Piccc without clamp, you don't get a shock and say, what happened? Is it the clamp loosen up? It might be also. It might be also if it's an open-ended catheter, or always come with a clamp, and or right side got clamp and left side don't have clamp, then it's suspicious. Maybe it spoiled or it dropped. But the HAHA product, where it's a closed-ended Cvad, it do not require a clamp. It comes without a clamp. That time you don't go and search for a clamp. Okay, don't feel surprised and thought it's a product 40 or what. Okay, so and yeah, the maybe present in tunnel catheter, implant port, Piccc, any product, you might see the closed-ended catheter. Okay, some valve present at the hub. See, this is where you put your stopper, right? The picture at the bottom. Okay, you see this, the valve at the hub there. When you infuse, it's open. The middle picture is where there are no pressure or no aspiration or infusion. It closes up nicely itself. And the third one, where you aspirate, okay, it's open up. So this valve present at the hub. Okay. And open-ended, this is always what you come across, and you need to always keep the clamp well clamped, because if you don't clamp, you can observe some blood backflow at the catheter, especially those products come with a transparent catheter, especially your non-tunneled catheter. Okay, some jugular catheter or what, it's transparent, right? Then you can see blood backflow if you did not do a proper flushing, or your clamp loosened up or did not clamp properly, right? So that's why you always require clamp, and the clamp usually built into the catheter, and open-ended catheter requires periodic flushing, and any type of CVAC also can be open-ended catheter. So this is two important feature that I want to introduce to you all. You understand better why when we perform procedure later on, or when you go to second topic, the complication and troubleshooting. Yeah. So let's go to the type of CVAC. I believe just now many times I repeated, right? So let's look into PICC now. Peripherally inserted central catheter. Okay, it's inserted peripherally, far away from the central vein, but however, very long and travel in your blood vessel, and the tip reach your central vein. Okay, it's a single, or it could be double lumen central venous catheter inserted peripherally vein, and the tip terminates in the superior vena cava. Some consideration: it can puncture the brachial, cephalic, basilic vein just above the antecubital fossa. Tip, yes, rests at the cavo-atrial junction. The catheter approximately 40 to 60 cm long. Okay, and maybe individually sized upon insertion, different size, okay? And they are catheter to double, triple, or some come, each lumen also same diameter, some got bigger and smaller diameter. That's why you can observe at the hub there, some product, the size of the lumen, or how do you know the size of lumen? Sometimes you can observe like 0.5 mils, okay, or 0.3 mils, or some directly come with 0.5 mm, okay. So some written at the hub, some at the clamp, okay, at the side of the clamp, the white color side. Okay, so if it's come bigger and smaller, I will advise when you go for higher viscosity solution, blood transfusion, TPN, please choose the higher lumen catheter, bigger lumen catheter. When you go for less viscosity fluids like your normal IV drip, or choose the smaller lumen one, it's okay. Okay, or either one okay, yeah. All right, PICC can chosen for patient requiring IV therapy for more than 6 days, or even can keep up to 1 year.
Oh, 1 year.
If you well taken care, okay, especially hemato case. Okay, they do keep this line, hemato or onco case, they need many cycles of chemotherapy, or they need transplant. They even keep this up to 1 year, months to year. Okay, so these are the advantages and disadvantages of PICC. PICC, we look at the advantages first, yeah? Okay, we need to assess by trained staff, okay? Not everybody can handle it, must at least a nurse. It remains in place for weeks to a year. It easily removed. You do not need to go into any operation theater or VIR room to remove it, where else chemoport you do require. Okay, so this one is easily to be removed. And the advantage compared to your non-tunneled neck, chest, or femoral line is this one, lower risk of infection. Okay, sorry. And lower infection rate, and external portion can be repaired. Okay, The disadvantage is you need to take good care. You need to do frequent dressing, flushing, okay? And it is if you compare among the CVAC, PICC is not the good CVAC for you to go for rapid infusion or high viscosity drugs catheter, because among other CVAC, I can say it's the smallest lumen catheter CVAC. Okay, among all the CVAC, it's smallest lumen. That's why it's not recommended for some medications such as phenytoin. Okay, phenytoin proven that it's a bit difficult to get flush off in the lumen, so it higher risk for occlusion. Okay, please take note. Okay, this is more on dressing. So for PICC dressing, yeah, we need to secure and fix the catheter firmly, because there's risk of pulling the catheter, migration of the catheter, and you can observe the catheter getting longer and longer. I will talk deeper when we look for when we go for second session of complication. Yeah. So to prevent that happen, please make sure you fix the catheter firmly. Some beginning of the PICC, you can see the suture, but sometime after you keep for few months, then you can the suture might wear off or drop. Then you need to replace with a stack lock. Okay, stick nicely on the skin. Yeah, the suture might be there as long as it's still intact, but sometimes it will lose and drop off. And PICC, you require cleaning. You need to change the dressing. And current research, chlorhexidine is the practice now. And within 24 hours post-insertion of PICC, usually we worried about bleeding or oozing. A gauze is placed under the transparent dressing. But however, after 24 hours, then we do not put gauze anymore, and we only place a transparent dressing, okay? So that we can observe the puncture site. Yeah, totally transparent dressing. Yeah, don't go for those dressing where you've got a little sponge at the center. No, not for that dressing. Look for a total transparent dressing. Any brand, okay, as well as big enough to secure, and you can observe the puncture site. And you're required to change the dressing every 7 days, okay? Together with the stat lock, if you are using the stat lock. So the stat lock also you need to change every 7 days, okay? How about bathing, showering, swimming with a PICC there? Okay, the advice is definitely you cannot get wet, okay? Of course, if the transparent dressing is well intact, it's waterproof, right? But however, to avoid getting wet, you need to advise the patient extra careful. Maybe they need to protect with some waterproof covering when they're bathing or showering. And swimming, definitely not advisable with a PICC there. So this is the advantage of a PICC compared to a pot, where a pot, when you are not using the pot, is totally planted underneath the skin, then you even can go for swimming. Okay, flushing of a PICC, the technique for flushing for all the CVAC are the same. You must practice Piccc push-pause technique with positive pressure finish. Okay, this one I will go in more detail when I teach the flushing procedure with some videos, so you can visualize better. No need to imagine now what do you mean Piccc push-pause. Okay, okay. So what to flush with? Okay, you see, with the closed-ended catheter, you can flush. Goshong is one of the example product of closed-ended catheter. So for closed-ended catheter, you're required to flush with normal saline, and you also lock with normal saline because it's a closed-ended catheter. okay? But for open-ended catheter, as you can see, the risk of blood backflow or reflux is higher. And therefore, we encourage to, yes, flush with normal saline in between your drugs, in between or beginning of using the line where you want to test blood backflow, or flushing whether any blockage or good patency, or in between changing of your antibiotic or whatever, you only required to use normal saline to flush in between solution. But however, when you want to stop using it, just want to lock it, you lock with heparin saline. And beside that, you also need to flush each lumen with heparin saline once a day. This is how to take care of Piccc. Okay, now we're still in Piccc here, because the frequency, the solution and are different among Cvad. Okay, so today I pick Piccc and chemopod, and because these two are more common. Okay. Hickman are more common in the tunnel catheter is more common in pediatric. Okay, let's come back to Piccc. The frequency of flushing for close-ended, when you are not in use, you only required to flush weekly with normal saline for each lumen. Don't forget, yeah. Now you understand why each lumen. For open-ended Piccc, you have to flush daily with heparin saline. Okay, and you do not require to disconnect continuously infusion to give this, because the bullet number 1 stated there, okay, daily I have to flush my Piccc each lumen 5 ml Hep cell. But bear in mind, if you have a patient admitted with a continuously IV infusion, such as normal saline 24 hours, correct or not? 8-hourly tripine continuously, you do not require to stop your IV drip and just flush your 5 ml heparin saline and continue IV drip. You do not require to do that because it's continuously in use. I hope I didn't go too fast or too nagging. Am I?
You can go faster, I think.
I can go faster. Oh, you're alerting me. My time is going. Okay. Okay. Implanted pod. Okay, it's a pod implant under the skin, but it travel tunnel. Okay, it's also travel tunnel under the subcutaneous layer. You see, it's tunnel under the skin. Okay, and the tip it reach the superior vena cava as well, yeah, central vena cava. So it's a pod venet under the skin. Of course, you need a minor surgical procedure, make a pocket to put the pod in. When you remove, when you want to remove it, also you need to do some incision. When you're not in use, you do not require, you need less maintenance compared to Piccc. You don't even need to do a dressing when you're not in use, right? But however, you still require to do maintenance flushing, but the frequency is, the gap is bigger than Piccc. Let me go in detail shortly. And it preserves client body image. You don't have a catheter tangling at your arm, you see? You can hide. And this implanted pod, you can implant any place that you like. You can implant underneath your under your armpit, or you want to put at the lower chest. Okay, it not necessary at your upper chest. Okay, I do have a stewardess who would like to wear low cut dress. She implant her pod under the armpit. So every time I need to insert the needle, she have to lift up her arm. Okay. So this when you assess a chemopod, of course you need a special needle, which is non-coring needle, to puncture through the pod, because we don't want to damage the rubber band. And the advantage of pod, as I mentioned, there's no external component, lower risk of infection. You do not require dressing, better body image. It can keep very long. And as long as the number of puncture of that product does not exceed, okay? Example, some some product allow you to puncture 5,000 times or 1,000 times or 500 times. As well as you not check exit the number of puncture, you can keep the pot forever. You don't even require to take it out unless you wish to take it out. Okay, that's what it means. It can keep very, very long, as long as the device is required, functional, and not a source of sepsis. The disadvantage of the pot is every time you need to use, you need to put in a needle. But this is also the advantage part because you can swim, okay? And the disadvantage, like I said, you will need to do a small incision to insert or remove it. Okay. All right. If you got question, you keep to the end, yeah? Because I pop up question to ask you, but better I go faster.
Can get ask question.
Yeah.
It's quite interesting when you ask question and it's the interaction. I like it. Okay. What I want to ask you at this point of time, how do you keep track of the number of punctures?
That's why it's never exit. Never. You don't need to keep track. Never. Where got people puncture a pot more than 500 times? Okay, and you see the most frequent, the most cycle regime that I come across is 12 cycle and maybe monthly blood test or what. Even though monthly blood test in a year also 24 times only, how to exit 1,000 puncture or whatever. You see? Okay. So usually we don't keep track and we don't count, but estimate. We do not exceed that number. So no one interested to keep count. Okay, but bear in mind, not other needle can be used, only non-coring needle, okay? Because we don't want to spoil the septum of the pot. Flushing. Flush, when you're not accessing your pot, you did not put in the needle, you do not infusing anything. Let's say you completed chemotherapy, you already on remission, okay? You only need to visit the doctor 6 monthly or even yearly for just normal medical checkup. If you wish to continue keep a usable pot which is not blocked, it's advisable you need to flush your pot 4 to 6 weeks. Okay, with 10 ml saline followed by 5 ml heparin saline. This is called maintenance flushing. Okay, the patient just can come to the daycare and tell the nurse, I have a pot and I just need to flush. The patient might not even have a doctor's appointment. Okay, and when you assess the pot, you must practice the bricks push pause technique. Okay, when you flush the pot. And what do you use to flush with? Same with any other Cvad, you just need to flush with normal saline in between your solution or medication. But if you want to remove the needle before you want to let the patient go back, you flush with 10 ml saline followed by 5 ml Hep-Cell. Then the next flushing required is 4 to 6 weeks later. Okay. Let's go into blood sampling. Okay, 40 minutes. I got 20 minutes more. Okay. Blood sampling and flushing. Okay, let's go to the steps of the procedure when you want to do blood sampling. Of course, followed by flushing. That's why I merged these two procedures together. First, you need to check the doctor's order. You have to check the lab form, everything correct. And of course, you have to check the right patient and also assess the patient condition, cooperative and patient understanding. And of course, you explain and introduce yourself. And also you assess the patient's Cvad condition, okay? Whether the Cvad in good condition or there's any sign of complication. And you prepare your blood tubes required, depends on what blood test been ordered and how many tubes, what color tubes, okay? And any other equipment needed, and prepare your environment, the height of the working station, the space, the lighting, and okay, privacy given. So this is the equipment that you need to prepare. Of course, you've got a tray to keep your alcohol swab, 10 mils normal saline, not in the picture, but don't forget you need also 5 mils heparin saline, your 18 gauge needle, 10 mil syringe, at least 3 or more, depends on how many amount of blood you need to aspirate, latex glove, and a mask and blood sampling bottles and receiver. Blood sampling for Cvad, it's a aseptic non-touch technique, okay? It is not a sterile procedure where you're required to open a dressing set, but I aware that some organization, they do open dressing set, they do, especially government hospital, they still open the dressing set, but as well as you practice ANTT, the aseptic non-touch technique, it's also fine, all right? Because when your sterile glove hold the catheter at like long line or whatever, the catheter is not sterile. So if you hold the catheter, it already contaminate your sterile glove. So usually I will opt for ANTT technique instead of do blood sampling with a sterile procedure, open a dressing set, sterile glove or what, because I can see the risk of contaminate your sterile glove or is so high. Okay, let's continue. After you prepare your equipment, you check patient ID and explain the procedure to the patient, provide privacy, get verbal consent, wash your hand, wear mask, and wear glove. This glove is an examination glove to protect you from biohazard because you are handling blood sample, okay? And expose and assess the Cvad, look for any sign of complication. Prepare the syringe and blood tube. Of course, you pre-open your syringe, so later easy for you to pick up your syringe, okay? And you label a sticker on the blood tube. And continue with use an alcohol swab to clean the connector or stopper. Okay. I know some of you would like to continue continuously rubbing the stopper for 30 seconds, or some just clean properly and wait for 30 seconds. This is important because you need to allow 30 seconds contact time with alcohol so that this chemical can effectively kill the microbe, okay? Then you prepare your syringe. Connect with your stopper, right? And this first syringe is meant to discard the first blood that you withdraw, okay? Because the blood that we withdraw might mix with the heparin saline that previously you push in, which still remain at the catheter, right? So you need to discard the first blood sample. For adult, you discard about 5 mils. For pediatric case, you discard about 3 mils. Okay? And you do not take this as your blood sample unless it's a blood CNS. For blood CNS, you don't need to discard the saline because you do not need to, you are not checking the accuracy of your blood sample with all the electrolyte or whatever blood count. The blood CNS, you are catching the microbe. So whether it mix up with a previous Hep cell or whatever is not important. So you do not discard the microbe. So for blood CNS, the initial blood sample, even though you know it's mixed up with any previous Hep cell, you just push into your CNS bottle, yeah? Bear in mind, yeah? For blood sampling, for any blood test, full blood count or electrolyte, whatever, you must discard so that your sample will be more accurate. And you see the point highlighted in this slide is you are only allowed to use 10 ml syringe or bigger, but not smaller for all Cvad. Okay, because the smaller the syringe you use, it creates the higher pressure in the catheter. Okay, and it might lead to complication. Okay, interested to know more? please join my second session. Okay? No time to explain.
Like a thriller. Like a trailer.
Okay.
Yeah.
So next is you now after you discard the sample, then only you withdraw. Okay, this is to discard, yeah, your sample, and then only you attach with your new another. That means the second syringe, your 10 ml syringe, to draw your blood sample. Yeah.
Okay, it is pink and diluted like that.
So this is your second syringe. After you discard your unwanted blood, now this is your blood sample which you wish to send for testing. Okay, the amount of the sample, it depends on what types of blood tests the doctor order, right? And then the requirement to put into the blood tube. Then you put your blood sample inside the blood tube. Okay, of course you connect to a needle. Okay, be careful. Stabilize your hand. And the vacuum inside the bottle will suck the and then mix well. Okay, at least mix the bottle tilt up and down for 10 times. Okay, then after that, it's time for your flushing. So this is your third syringe, right? You should third and fourth syringe. Even you need the fourth syringe for 5 ml heparin saline if you do not going to use this Cvad anymore, or you even intend to off the needle, or if you're going to start any infusion, then you just required to flush with 10 ml saline, then you can start your IV infusion. So the flushing technique, so this is procedure number 2, flushing. Okay, you must use the push-stop technique or the turbulence flushing technique, followed by positive pressure, then immediately clamp. So what does it mean? So you pay attention to this video. Push, push, pause, push, pause, push, pause, push, positive pressure clamp. See, when you're continuously pushing, you are creating a positive pressure, and you can imagine at the tip of the catheter, there's continuously streams flowing out from the tip of the catheter, and you do not allow any blood backflow to the catheter, and you immediately clamp. So this is what it means by positive pressure, then you clamp. Okay, you don't push and then relax, take your sweet time, then only go and clamp, then you are allowing the blood might already return into the tip of the catheter and travel in the catheter. And after maybe 4 weeks later, that blood backflow already become a clot and it's already blocked the catheter. Okay?
I see.
So this is, I repeat the video. So turbulent or push pause technique followed by positive clamp. This is what it meant. All right. So this is the crucial technique, the most important tips for you to prevent Cvad blocking. It's not about the amount of solution. It's not about what kind of solution, whether it's a Hep cell, is a neat heparin or whatever. That's not the point of preventing Cvad occlusion. The crucial, the golden advice to prevent Cvad occlusion is your flushing technique, not what solution you use. Okay? Even you use a neat heparin, but your flushing technique is out, it's wrong, you allow blood backflow into the catheter, it is still blocked. All right, so please bear in mind. All right, so after procedure, as usual, we need to tidy up, comfort the patient, place your blood tube into the biohazard bag, wash your hand after procedure, send the blood sample to lab, and of course, documentation, procedure done, your Cvad, no redness, no discharge, and good patency, dressing intact, yeah, all those documentation, right? Reminder, recap some of the important tips is if patient on IV drip, how to take blood sample. So the tip is please stop your whatever infusion, clamp it for half an hour. Okay, then only you disconnect and you then only you connect to your syringe to draw your blood sample. Okay, for better accuracy. If you got a double lumen or triple lumen, you are just required to clamp your infusion and use another lumen. Okay. Use syringe size 10 mils or bigger. Do not use 5 mils or 3 mils syringe, even though you are giving only 1 mils medication. Yeah, although it look very silly, like draw 1 mils medication in the 10 mils syringe, but this is crucial. You only allowed to use syringe 10 mils and above for Cvad, even though you are giving 1 mils medication. Yeah, this is to prevent another complication. Okay,
which we will talk about next week.
Yep. Thank you. Yeah. So, okay, discard 5 mils blood for adult and 3 mils for pediatric. And do not discard if you taking the sample for blood CNS. So, and you have to change stopper after blood sampling because the possibility of the blood left behind at any parts of the stopper, it could lead to infection. So it would be good that change the stopper. Okay. Okay. A situation that exception for taking blood from Cvad. In what condition that we are not advisable to take blood sample from Cvad is during for blood coagulation profile. So blood coagulation profile, you do not take blood sample from Cvad. Yeah.
Oh, even if you drawn out. Okay.
Yeah, it's not advisable. Yeah. So you, even though you got Cvad, if you want to take blood coagulation profile, it have to take from your brachial. Okay. And when infusing TPN, you do not disturb in between TPN. Yeah. You do not disturb while you're infusing chemo. You do not disturb while you're infusing blood products. Okay. So these are the conditions that you do not take blood sample from Cvad. If you can wait for the blood transfusion finish, okay, then fine. You still, after the blood transfusion, you take from the Cvad, or else you take from the peripheral line, okay, brachial or puncture, okay, venopuncture. Okay, lastly, dressing. Dressing is similar to any other dressing, okay. For Cvad, it's like a normal dressing for your wound or whatever. So you have to assess patient condition, prepare your dressing usual requirement, equipment, prepare your environment. This is the common dressing requirement. Dressing pack, your cleaning solution.
Okay, sorry.
Okay, so normal saline will do for the cleaning solution, and after change the dressing, you need a new transparent dressing. And a lot organization also practice wearing sterile glove, but some don't because it's like a normal dressing. So you are non-touch, you got your forceps. So some do not practice wearing sterile glove. It's fine actually, yeah. As well as you are not contaminate your forceps, that is fine, yeah. And masks. So step one, as usual, you have to carbolize your trolley, and then you wear your mask, wash your hand with proper hand washing technique, and you wear your examination glove to remove the old dressing, right? Look at the picture, the first picture, right? You wear, this is to protect yourself from biohazard. And you inspect the catheter site for any sign of infection, such as redness, tenderness, swelling, or discharge or pain. Then Of course, you discard the old dressing, you remove your dirty glove, right? And then you wash your hand, then you open your dressing pack. After that, you start maintain the aseptic technique, yeah? Pouring your normal saline and open your dressing, transparent dressing or whatever things that required to put in your dressing field. Then again, you wash your hand because just now you touch a lot of packages, right? Yeah, after you wash your hand, dry with your dressing towel. At this moment, you may wear your sterile glove or it's optional as well. Now you're picking up your forceps, right? Of course, as usual dressing, you start squeezing your cotton, prepare all your things, arrange your equipment, right? Now, when you approach to the puncture site, you use a swab, apply gentle pressure and cleanse the exit site, starting at the catheter, puncture site, and working outward in a circular motion, okay? And never return back to the exit site, okay? And then if you're not satisfied, it still got blood clot, it still look dirty, you can repeat second swab at the same spot, okay? You don't move outward yet, okay? You can repeat spot number 1 with 2 swab or even 3 swab. So that's why just now when you open up the old dressing with your examination glove that time, you can evaluate whether sufficient cotton, because usually there's only 6 cotton in your dressing set, right? So after you open up and you see how dirty it is it 6 cotton sufficient or not? Or where you prepare your dressings field or dressing set that open up your set, you need to open another pack of cotton or not? At that time, you make the decision. Okay, so then you clean until you are satisfied with no more old black clot, no more old stains, all those things. Then you repeat the steps until thoroughly clean. Then you clean outward, okay, and allow to dry. You may swab treat. You have to swab the coverage, how broad you have to cover, how wide you have to cover, all right? So at least 3 inches of the catheter extending from the exit side, okay? And then after the procedure, you apply transparent dressing, any brand as well as it's transparent so that you can assess the condition of the puncture site. Then you remove your glove if you are wearing the sterile glove, and then you wash your hand and do proper documentation that you already changed dressing, you clean with what solution, and then you cover with what dressing and what date, what time, and what is the condition of the exit site, any redness, any sign or whatever. All right, so proper documentation. Okay.
Well done. Keeping to time.
Yes, thank
Okay.
you.
Okay,
Right.
so are there any questions? Can I start with one first? I'm very interested to see again that needle that is special for the chemo pot, for the pot. Okay. So just now you say, okay, let's say we use, we have actually put an infusion and then you want to take blood, you wait for half an hour. Is that not true?
Am I sure? Pardon, doctor, sorry?
Okay, so I'm interested in that needle. Okay, so I want to see what is at the end of that needle.
The non-coring needle?
Yeah, the special needle for the chemo pot.
Okay.
The special needle for the chemo pot. Lower down, lower.
Wait.
Are there any questions? If you have any question, please send us on chat or raise your hand. And while she's looking for the pictures, okay, we are going to send you the e-cert. I have to do it personally, so I think tomorrow afternoon or by this weekend, I will send you the e-cert. You can insert it under your A4 documentation for CPD points, right? And because today is our first session, okay, that we will send to anyone who attended this CPD lecture by webinar by Ms. Ho. But eventually we will have a cutoff point of, let's say, 75%. Oh, so sorry. I muted everybody. So, okay. So, can you show us that, where is our friend? Miss Ho, where are you?
Yeah, I'm looking for a nice picture to show you.
Oh, I see. Okay. While you're looking for the picture, Muhammad Zai asked, can we have the slides from the present? Okay, I will ask Miss Ho to give me the PDF if it's okay with her.
Okay,
And then I will share it with you guys in the medical forum that we have. And Emmeline asked whether I understand that when we take blood from the CVAD, we need to what is it? We need to clamp, is it? Do we need to stop infusion? Do you suggest just clamp the tubing or disconnect the whole tubing from the...
Or just clamp it will do. Just clamp it will do. It's not necessary to disconnect if you got double lumen or triple lumen. But if it's a single lumen, after you clamp, you also need to disconnect because you need to use the only lumen to connect to your syringe, right? So either no right or wrong. If you got more lumen, you not necessary to disconnect, you just required to clamp. But if you only one lumen, at the end, you still have to disconnect to connect to your syringe, right? Did I answer the question?
Okay.
Yeah.
This is the needle for the chemo port, right?
Am I showing my screen? I am, is it?
Yeah, that's
I'm
right.
sharing screen. Yeah, okay. I thought I'm not yet shared. That's why I'm working on it. All right. So let's see bigger picture. Oops. Okay. So this is how the cross section of the pot look like in a cartoon. Okay. So it got reservoir here, and this one is a septum, which is a rubber band. Okay, and it's highly compressed. Okay, and after you remove the needle, it will seal off the puncture site. So we don't want to damage this septum. If you use a coring needle, just how you okay, example, you inject 1 gram KCl into the IV drip bottle, normal saline bottle. Sometimes you might realize after you puncture your 18 gauge needle through the rubber band of the normal saline bottle, you find difficulty to shoot in your 1 gram KCl inside, and you realize your needle been blocked by a little piece of rubber in your needle. Okay, those are coring needle. It will core up the rubber band. Got it? So you must use non-coring needle, and the sharp edge of the non-coring needle, it looks like the left picture, where it do not have the cutting point to core your rubber, your septum. Okay. Can you imagine if you use a standard needle, then it will core a piece of your septum, and it might stuck in the needle, or it create a little hole and it spoil your septum.
Okay, before we proceed, I want to say that please do not give 1 gram KCl bolus to any patient.
You must shoot into a pint of normal saline, just now I highlighted.
Please.
Okay.
Okay, the patient may go into asystole. Okay, please remember, never give IV bolus of potassium. Okay, ever.
So Dr. Betty, I hope this picture can clear your...
No, I'm not the... Go back to the previous...
Okay.
Okay, I'm not worried.
Person who asked.
I want to ask, see the other end of that needle. The previous picture, please. Okay, I want to see the one that is... okay, so you put in the needle. You put in the needle, okay, you put in the needle, and then you can actually put in the infusion through here, right?
Yeah.
Okay,
Can you see my mouse?
Okay, that's right. So what happens if it's double lumen?
Oh, as I told you, pot also got double pot, right? The double lumen is not at the needle lumen. It's not at the non-covering needle. The double lumen is at the pot. You remember the picture I showed just now? Yeah, you see, it's double pot.
Okay, so you have two needle then.
Yes, when you got a double pot, the catheter is got a separator. Okay, in the catheter of this pot. So when you want to access the double head pot, then you need to put two needles, and you use separately. And you have to flush both pot. If you perform the maintenance flushing, you have to put puncture the left and right.
Okay, Emmeline asked, if doctor asks us to do a neat heparin lock, how many mils do we need to flush? Doctors will not be able to tell you because I also don't know. I think it is part of
First of all, it's not a standard practice to lock with neat heparin. And if you really want to give this neat heparin lock just to keep the neat heparin in this catheter, and your intention is not give IV heparin into the systemic. You get my point? So the amount that required to insufficient to fill up the lumen of this catheter actually is very, very, very minimum, especially at Piccc. You might only require half mils to fill up the whole Piccc, or some bigger Cvad, maybe you need about 2 mils to fill up the whole catheter for Hickman, because Hickman got a bit bigger lumen, and it also very long tunnel under the skin, right? The tunnel catheter. So the most is about 2 mils is sufficient to fill up the lumen in the catheter. If you give more, if you give 10 mils of neat heparin lock, actually you are giving 8 mils of IV heparin into the systemic and only keeping about 2 mils locking in the lumen of the catheter. I hope this answers your question.
Okay, so never mind. But no, so Haiza is asking something that
sorry, I come back to just now the question. If ask me how many milligram or how much, I think that's what is doctor prescription, right? Because it's a neat heparin, it's a high risk medication. It need doctor prescription, so let's the doctor to prescribe. Correct now? Yeah.
Oh, you mean neat heparin? Okay. I see.
So the dosage is prescribed by the doctor, but if you ask me if the amount that required sufficient to fill up the catheter, that one I can advise lah.
Well, I don't think that you would give very much of neat heparin, you know.
That's why I start with the standard of flushing Cvad. We do not require
give neat heparin.
Yeah.
Because neat heparin, even like 2 mils of neat heparin will already actually cause quite a lot of anticoagulation defect, you know, that is unnecessary.
So that's why just now my sharing also is heparin saline, right? Never go for neat heparin.
Yes. Yep. So Haiza asked, why cannot take coagulation profile from the Cvad?
We will doubt with the accuracy lah, because the Cvad, the inside the Cvad, you might already have some remain clots, or it might have remains of your Hep cell, or even so. If you want a very good accuracy of your coagulation profile, then you directly perform venopuncture will be more advisable. Okay, I hope that answered the question.
So Lisa asked, Malaysia, yes, I've come across, they take 1 ml of heparin with 5 ml of normal saline, then flush and lock. Oh, basically you diluting your
Yep.
heparin into your normal saline, so you might as well use heparin saline that is already pre-prepared sometimes. Okay.
But heparin saline, the concentration of heparin is 10 unit per ml. But I do come across some article, instead of heparin saline, they use still heparin saline, but they can use up to 100 unit per ml. And that's the most I come across. I did not go for even neater heparin. Okay, the highest concentration that I read with many articles, the highest that I come across also 100 unit per ml heparin saline. Yep.
Okay, so Lisa asked, how about maintaining flushing for chemopod? Latest update is normal saline 10 ml plus and 5 ml of heparin. Is it?
Yep. Yep, correct. Very good.
Oh, very good. This you even you're updated and then you're doing evidence-based.
Yep.
Okay. So if there's no more further questions, I would now stop the live stream and then stop the recording.